Great. Well, good afternoon, everybody, and welcome to the Skyland Trail webinar, Transcranial Magnetic Stimulation for Depression. I'm Beth Finnerty. I'm the president of Skyland Trail, and I'm pleased that so many of you could join us today. We've all been through quite an unexpected upheaval these past few months, and I hope that you and your families are all healthy and staying safe out there. Before I introduce our speaker, I wanted to just share a quick update with you on how things have been going at Skyland Trail. Throughout the pandemic, we've been operating with one goal in mind: to continue to provide as robust services as we can to the clients and families who are depending on us. Our residential clients, both our adolescent and our adult clients, have remained on campus, and our clinical team has been using appropriate measures to ensure the health and safety of our clients and staff. We're admitting new residential clients weekly and taking extra precautions, including PCR testing and initial quarantining to protect the health of our community. All of our day treatment clients have moved home and are participating in virtual group therapy and individual therapies. While we've been very focused on urgent and immediate challenges, we're beginning to start thinking beyond tomorrow and about how we can be prepared for the increased need for mental health services that will certainly arise once this pandemic is over. I think it's going to take all of us working together to help meet our community's needs, and all of us at Skyland Trail are looking forward to working with you, our partners in the field, and our friends in the community to support adults and adolescents and families who are struggling with mental health issues. So thank you again for joining us today. I know it's going to be a great webinar, and it's really my pleasure now to introduce our speaker, Dr. Ben Hunter. Dr. Hunter is the Medical Director of Outpatient Services at Skyland Trail, where he oversees all outpatient services, including our medical clinics at both the adolescent campus and the adult campus, our TMS practice, outpatient psychiatry, psychological services, family therapy, and our healthy eating and active living metabolic program that we call Healthy Challenge. Dr. Hunter completed his medical training at Emory University, followed by his psychiatric residency at the University of Pennsylvania, where he served as chief resident during his final year. Additionally, Dr. Hunter completed fellowships in psychoanalysis through the Psychoanalytic Center of Philadelphia and organizational psychiatry with the Group for the Advancement of Psychiatry. During his training, he received numerous awards, distinctions, including the University of Pennsylvania's Laughlin Foundation Award for Outstanding Professional Achievement, as well as the Kenneth D. Cohen Psychodynamic Psychotherapy Award. A fun fact about Dr. Hunter that you may not know, you probably don't know, but his career in healthcare has been informed by his lifelong involvement in team sports. He had an All-American baseball career when he was at Wake Forest University, and he was drafted into the Major League Baseball. He was drafted by the Major League Baseball, but he ultimately decided, lucky for Skyland Trail, that medicine was his calling. Dr. Hunter continues to share his athletic passion by advocating for healthy lifestyles as a critical element of physical and emotional well-being. We are so pleased and lucky to have Dr. Hunter with us at Skyland Trail as our Medical Director of Outpatient Services. Dr. Hunter, I saw you on the screen somewhere, so I'm going to turn it over to you.
Yeah, thank you, Beth, and thank everyone for attending today. I don't think there's a better time to look at the intersection of mental health and physical health than in a pandemic like this, and I really appreciate everyone taking an hour out of their afternoon to think about mental health and some of the consequences of a pandemic situation like this, and luckily to look at a very exciting and kind of evolving treatment that we have available to help people with depression and anxiety. So I think it's a well-timed symposium as well. I'll go ahead and share my screen here so you can see the slideshow. Bear with me for just a second. One note as we get started, what we'll do is have everyone type in questions in the chat function. And if you don't know how to do that, just kind of look around the screen a little bit, you'll see chat. You can type in questions. Address them to everyone. There's an option for individual side chats or to chat to everyone. Please and write your questions addressing everyone so that we can all see what's been asked. I will probably hold off on answering them until the end, just for the sake of time. I've got quite a bit of information to get through, but Dawn is going to be keeping a close eye on them, and she's going to compile some at the end try and pick some of the most salient questions to answer. So without further ado, and I appreciate everyone helping by keeping their microphones muted during this as well. So again, today we'll talk about transcranial magnetic stimulation, a treatment for depression and soon to be a treatment for many other mental health issues, and some of the applications, new advances, and indications that we're learning, month by month, really. I have no disclosures or financial conflicts of interest. So we'll talk a little bit about neuromodulation as a whole, TMS being one mode of neuromodulation. We'll talk about the history of TMS itself and the neuroscience behind the treatment. We'll talk about what patients are eligible and ideal for TMS treatment. We'll talk a bit about what TMS entails and what the experience is like for patients. And then we'll talk about sort of the next directions that TMS is heading, new research and science, and what it might mean for the field moving forward. Okay, so first to outline, the concept of neuromodulation. So neuromodulation, again, including TMS and several other therapies, is essentially defined as both non-invasive and invasive techniques that are designed to stimulate nerves or neural networks of nerves in a targeted fashion, typically. The goal is modulating these pathways in a way that corrects the abnormal physiology created by disease processes. So, in other words, returning someone's neural function to normal, or to the way that it functions most typically. Some examples of neuromodulation: transcranial magnetic stimulation is one, deep brain stimulation, or DBS, is another. Vagal nerve stimulation is a third, as well as actually the most common form of neurostimulation, neuromodulation, which is spinal cord stimulation. People have spinal cord stimulators often for paralysis or pain related to spinal injuries. We also lump electroconvulsive therapy into this group of treatments. And just one quick plug for electroconvulsive therapy, certainly has gained quite a reputation over the years based on largely incorrect media portrayals. Electroconvulsive therapy is still the definitive treatment for depression. It's also an excellent treatment for bipolar disorder and mania and psychosis. It's incredibly safe. It's used in a variety of situations. So just one more voice indicating that if ECT has been recommended by a psychiatrist or another medical professional, or if you're looking at a patient who's severely depressed, please keep ECT, electroconvulsive therapy, on your menu of options. It is an incredibly potent and now well understood treatment. So why do we need neuromodulation and TMS? I don't think any of us are ignorant to the fact that depression is a huge issue worldwide. It affects 16.2 million Americans as of 2016. It's only growing. And probably more concerningly, it's not something that we treat particularly well with our standard treatments. If you think about depression as a whole, for someone who walks into their psychiatrist or primary care office and gets prescribed an antidepressant, we tend to say there's about a 50-50 chance they will achieve relief with that antidepressant. That's any patient, first time being treated. Unfortunately, outside of that 50% who achieves relief with just their first medication trial, it turns out that about 30% of people, again, kind of a round number, but in many studies, about 30% of people will actually prove to be treatment resistant. And one of the more famous studies for depression treatments, and especially step therapies for depression, is called STAR-D. And it turned out, again, about 30% of patients with major depression didn't achieve remission after all 4 treatment steps. So that's essentially 4 sequential steps to treat their depression. And it really turns out to be even harder in real life when you're not in the protocol and having regular follow-up. We know that people who have treatment-resistant depression, or TRD, end up being less productive in their lives. They have higher degrees of medical comorbidity, so all the other medical issues that come along with mental health issues, and quite frankly, often impact people to a larger degree in terms of their actual mortality and severe morbidity. And then we know they have more suicide attempts. So obviously, the worst possible outcome of depression is something that occurs more frequently in treatment-resistant patients. The medications we have to treat depression, they are well understood, they are fairly effective, but they leave a lot to be desired. So what you have here, and I won't go through all the details, but essentially an outline of the STAR-D protocol. So again, a stepwise treatment protocol for depression. By the time you've reached the 3rd or 4th level of this, so in other words, patients who have failed multiple medications and psychotherapy, by the time you're in that group of people, you're looking at about a 5% at level 3 or 3% at level 4 percentage of patients who remain in remission at a year. Just not good numbers, right? So even if we're able to achieve effect initially, we don't sustain it very well. We know that the medications we use, once we're starting to get into the latter stages of treatment for depression, have high levels of side effects. So up to a quarter or a third of patients are starting to experience side effects to the point that they can't actually continue them. And we also know that we need treatments for people who are somewhat more vulnerable, right? So patients who are pregnant, younger patients who you may not want to expose to psychotropic medications, children and adolescents, and then older adults who might be dealing with other medical comorbidities that make it harder to take medications in a safe way, and or patients who are prescribed many medications that'll have interactions and create issues in that manner. So again, looking at a treatment that directly targets the nervous system is very desirable given all those facts. And then just one more kind of punchline for this. In a famous study, a researcher named Dunner and his colleagues looked at 124 people, real world treatment-resistant depression, and looked at how many of them were able to achieve remission, or excuse me, response at a year. So response is just essentially a somewhat robust reduction in their depression symptoms, 50% or more. Only 10% of patients in their study were able to maintain a response, so some level of successful symptom mitigation at a year. Not good numbers. We need more treatments that are, again, more effective, have fewer side effects, and we can use more confidently in special populations. I don't think there's a better time to talk about this than right now. We know that depression and other mental health issues are biopsychosocial illnesses. They're biological in their sort of underpinnings in neuroscience, in genetics that we know transmit mental health issues. They're psychological in the way people view themselves, in the way they affect their self-esteem, and the way they view themselves in the world. And they're social. They're impacted by our ability to interact with other people, form relationships, and manage those relationships. And COVID is really threatening all of those aspects right now. A recent APA poll, the American Psychiatric Association, polled 1,000 people and basically found out that over a third of people are not just viewing this as impactful on their mental health, but have said that this is causing serious issues in their mental health. So even for folks who were doing relatively well before this whole situation, it's really challenging their resilience in a way that makes, again, access to new treatments very desirable. So here's where we come to TMS. So just a little shot there of our TMS room. That is a kind of a typical looking transcranial magnetic stimulation setup. And just, we'll go through this in quite a bit more detail, but you can see there the chair with the magnet attached. If you can all see my pointer, this is actually the magnet that I'm circling with my pointer right now. It's a powerful kind of MRI level magnet that we use, and it's, again, attached to the chair, which is relatively comfortable. And then you've got a computer system driving it. What you can see over here is the handheld device that we use to measure motor threshold. And again, I'll get into those details in just a second, but that's our room. We find it to be a pretty pleasant place to do TMS, some nice natural light. So it's a little bit of background on TMS. FDA approved in 2008, so it's not new. I think we tend to think of it as new because it's been relatively recently adopted in the broader sense, and because we keep getting new information, new protocols, and new indications. More diseases we can treat with TMS almost on a monthly basis at this point. Essentially, the device uses electricity to generate a magnetic field. 1.5 to 3 Tesla magnet. Again, that's sort of on the order of MRI machines for imaging purposes. And then if any of you remember Faraday's law from physics class back in high school, I certainly didn't until I looked this back up for TMS applications a couple years ago, but you essentially have a correlation between magnetic field and its ability to induce electrical current in the brain. So we take advantage of that relationship to actually use TMS in the brain. The electrical current that is induced by that magnetic field affects the neurons in a very targeted way. We're looking at a system called the limbic system. And that limbic system will then modulate mood and anxiety, among many other functions. So again, magnetic field induces electrical current in a targeted manner in the brain. We modulate the limbic system using that electrical current and the neurons associated. So here you have a picture of the brain, and what I've highlighted in blue here is the dorsolateral prefrontal cortex. It's an area that we know is sort of a gateway to the limbic system. And what we know even further than that, based on functional imaging and other studies we've done, is that the left side of your dorsolateral prefrontal cortex, again, symmetrical in the brain, like most brain anatomical structures. You got one on each side. On the left side, that dorsolateral prefrontal cortex is hypoactive in depressed patients, so it is not functioning at a normal level. What we do is we treat that using excitatory, we call high frequency pulses with the TMS machine. On the right side, on the other hand, you've actually got a hyperactive dorsolateral prefrontal cortex. So we actually inhibit the activity on the right side by using 1 Hertz pulses. And what happens is when you're leveling those two out, you're kind of, in a way, also regulating the two hemispheres relative to each other as well. You get better synchrony between the two hemispheres, it seems. And just as a bit of a spoiler here, that seems to be why we get a good positive benefit with anxiety as well. The idea is that discordance between the hemispheres might drive anxiety from a biological standpoint. So bringing them back towards the middle, so to speak, seems to help with anxiety quite a bit as well. Again, we're depolarizing local neurons, essentially changing their function in a way that returns them more towards the way they would function in the person's brain when they're not depressed. And we hit that limbic system that's involved in emotion, behavior, motivation, memory, smell. Interestingly, you can everyone can probably attest to the fact that smell is one of the most commonly associated senses with memory, and that's the reason why. So again, activation of that limbic system mechanistically seems to stimulate release of neurotransmitters. So same thing that some of the medications do, right? They make serotonin, norepinephrine, dopamine, other neurotransmitters more accessible to the brain to use in a way that actually, helps raise mood and regulate mood. Blood flow and glucose metabolism rise, indicating that things are functioning more on their normal level. And neuroimaging studies actually show that there's improved functional connectivity between regions of the brain that should be connected, and that the connections that are made between different areas of the brain, again, start to mimic the connections that are made in the brain when it is not depressed. This is why we think this has a long-term antidepressant effect. Again, we know that there's things happening during the session, but obviously this would not be a useful treatment if the effect didn't continue past the first, 40 minutes that somebody's in a chair. This is what allows it to impact them on a longer term basis, partially through the GABA system, which is sort of an anxiety modulating system, and the glutamate system, which also regulates mood and excitation of the brain. Here you can see a sample of how the magnet's actually placed. See, it's sort of targeted right to that area you can see in blue on the middle picture. That corresponds if you were to rotate the head slightly. And then sort of coming through at an angle, it accesses the limbic system by way of that dorsolateral prefrontal cortex. So who are good candidates for TMS? Ideally, right now, based on FDA approvals, it's someone who's in the midst of a major depressive episode, so struggling from depression symptoms in a way that's significantly impacting them. The FDA, Food and Drug Administration, indicates at least one failed trial of an adequate medication and at an adequate dose. So essentially something that's approved for depression at a decent dose has to be failed before we try TMS. Insurance companies will require slightly more than that in order to reimburse it. That's typically 4 medication trials to prove treatment resistance. We call treatment resistance probably anything upwards of 2 or 3 failed trials, but that's what your insurance company would typically need to reimburse that. You usually also require one trial of evidence-based psychotherapy, like cognitive behavioral therapy, psychodynamic therapy, or dialectical behavioral therapy. Although it should be noted that, again, just because someone doesn't quite meet those criteria doesn't mean we can't necessarily do the treatment. It just probably means that their insurance may be less likely to cover it. We will treat patients with bipolar depression with an adequate sort of risk assessment and understanding from the patient. We'll treat people for anxiety with TMS, and we'll treat people who otherwise just are not interested in medication therapy for a variety of reasons, or who can't tolerate medications. Reasons why you wouldn't be a good candidate for TMS. The only absolute contraindication is a metal implant or other metallic device within 30 centimeters of the magnet. So again, you can picture that magnet on top of the head. Anything within 30 centimeters will unfortunately probably be affected by that magnetic field in a way that actually can cause heating. And we don't want to be heating up metallic implants or other sort of intracranial devices. Cardiac pacemakers, vagal nerve stimulators, other things that can be affected by magnetic field are also contraindications. We look at history of seizures or epilepsy in the patient or family, history of mania in the patient, so bipolar disorder diagnosis, significant head trauma, brain infections or spinal cord infections, and history of psychosis, as well as substance abuse, as reasons to pause and think about the risks associated with TMS. They are not absolute contraindications, though. So here's what we do, and I'll start by saying, kind of where we started. So back in 2008 and really up until probably 2016, 2017, we were kind of doing things the same way. First thing we would do is check the motor threshold. And the motor threshold is essentially the amount of power using that handheld magnet that we need to stimulate the brain and using a single pulse, basically get the patient's right thumb or forefinger to twitch. So if you look at the diagram on the top here, we would place the handheld version of the magnet right here at C3, which we map out using head measurements. And then we would essentially try a bunch of different powers with the magnet, whichever the lowest power was that we could actually get to achieve that thumb twitch, and literally their finger would twitch physically. Whatever the lowest power that we could effectively get that twitch was called their motor threshold. And then using the old version of treatment, you'd literally just take that measurement at C3, wherever that best spot was where you got the most robust twitch, you'd measure 5.5 centimeters anterior, and that's where your F3 location would be. So looking down at on the top view here, from the top down, here's where your motor threshold would be measured at C3. If you move straight forward 5.5 centimeters, here's where F3 is. You may be asking yourself, why would you use the same exact distance from C3 to F3, given that patients' heads vary in size to quite a significant degree? And we'll get to that in a bit. The answer is we don't necessarily do that anymore. We don't use that measurement anymore, but it's been the gold standard since TMS was invented. Okay, so then once we've got that frontal spot measured, that F3, the spot that's on the kind of the front corner of the skull, you turn the magnet on, and the machine's set up so that it turns on for 4 seconds of high frequency burst, and then it turns off for 26 seconds, so you get a bit of a break. You do that essentially 75 times. You repeat that 4-second, 20-second cycle 75 times. You get 3,000 total pulses delivered to the dorsolateral prefrontal cortex. It takes 37 minutes, and that's your session. So that's one session in terms of the old protocol. You would do that 5 times a week, so Monday through Friday, for 6 weeks. So that's 30 total, and then you do a 6-session taper. So 36 total sessions, 30, and then a 6-session taper was sort of the gold standard, and that was what they found both to effectively treat depression, but also not be overkill. It seemed like the benefits started to diminish at 36 sessions. Now, what we found out further, and there was a large study conducted actually at University of Pennsylvania by one of the researchers I worked with in residency, and essentially what he found from doing lots of real-world studies with TMS is that the effectiveness of the treatment is improved if you can customize it to the patients, both their physical attributes, the attributes of their depression, and their response. So now what we use is called the BEAM method. And the BEAM method is essentially, without going into detail, it's a method of measuring out where that F3 spot is, where we correlate the dorsolateral prefrontal cortex, taking into account seemingly important things like head circumference and the distance from the front of their head to the back of their head. We do have evidence now to show that there is a significant difference between the effects with BEAM and the old effects with 5.5 centimeters, which was our previous rule. And we've been using BEAM since day one. Most people have, so it's not shocking to hear that. But it turns out most people are actually further than 5.5 centimeters between those 2 points. So that's one way to improve effectiveness. The other way is that we added in, as I'd mentioned previously, that ability to do right-sided low-frequency treatment to inhibit that hyperactive right dorsolateral prefrontal cortex. Again, I think that's something that seems to help with anxiety, besides just adding in another method and a secondary kind of equally evidence-based way of treating the primary depression. So the right side in and of itself is evidence-based to treat depression. You add both of them together, left and right, I think you get an even more robust response based on all the research we've done so far. And then variability in pulse volume and sort of the time between pulses. What we've generally done is increase the pulse count as people have gone through treatment if they're not experiencing the effect they would desire, or if they don't seem to be making progress in the way that we would expect. We have also cut down, as of many other centers, cut down the amount of time from 26 seconds to about 12 or 14 seconds between trains so that we can get people in and out with left and right-sided treatment in 35 or 40 minutes. That's a tolerability factor more than an effectiveness factor. But again, if you're coming through treatment, and Skyland Trail uses a similar protocol to University of Pennsylvania and Emory and some of the other academic centers, you can expect to be in the chair for about 35 minutes for your actual treatment, add in about 5 or 10 minutes to place the magnet and make adjustments between the left and right-sided treatment. The patient's head is immobilized lightly, meaning it's in a head rest. It's not pinned into place, but it is movable if they become anxious or otherwise need to move their head slightly. They are able to read or watch television. We have it set up so they can watch Netflix if they'd like. We encourage meditation or other kind of mindful activities as well. While the treatment is being administered, they can expect a fairly loud clicking sound. If any of you have ever had an MRI or heard an MRI machine, that is not totally dissimilar. It's slightly less noisy than an MRI machine, but sort of the same caliber of sound. We do have patients with earplugs in to prevent any hearing damage. There's no evidence that it causes hearing damage. And the beautiful thing about TMS that you don't have with electroconvulsive therapy is that there are no cognitive side effects. Patients literally will come in at lunch and then go right back to work, or come in the morning before work or school, otherwise get right back to their activities, as if nothing had happened. And in fact, it seems there may be a little bit of a cognitive boost that happens as a result of stimulating the prefrontal cortex repeatedly. So I won't make too broad of a statement on that, but it certainly doesn't hurt. You can expect about 3 or 4 weeks before most patients will start to see clinically meaningful results in terms of their depression lifting. So this is not an emergency treatment, so to speak. It's something that if a patient is stable enough to tolerate a few weeks of build-in time, we can really get them feeling better by about a month out. And then they continue to get better over the course of the remainder of the treatment. They can continue their medications with no real adjustments required. I always coordinate with their outpatient psychiatrist or their psychiatrist at Skyland Trail when they're in our program to make sure that I'm aware of any changes, because we may remeasure their motor threshold. But other than that, they are allowed to continue their medications as if nothing had happened, and they continue their psychotherapy. And then again, another main point here in terms of what to expect. I mean, if this was unrealistic financially for patients, it wouldn't be very useful for us right now. It has been extremely well covered by insurance plans, and basically is covered by all major insurance plans at this point, which only shows you how effective this treatment is. It's a treatment that will cost the insurance company somewhere between $10,000 and $12,000, which is also kind of the typical community average cash pay rate if it's not covered by insurance. But insurance companies are relatively quick to pick up this treatment and encourage their patients to engage, which only, again, tells you how effective it is, and also how much it's ending up resulting in improvement in their patients that's long lasting and resulting in less utilization of their healthcare plans overall, which is how health insurance companies think. So not to be too cynical, but I think we can take that as a good indication that this has been effective. Side effect wise, this is something that every patient wants to know, and I don't try and sugarcoat this and tell patients that they're going to come in for their daily head massage. I don't think it's quite that therapeutic in that way. Most patients will describe kind of a tapping sensation on their scalp at the site where the magnet is located. That's just it's not actually physically hitting them, but the sensation of a magnetic pulse is somewhat like a tapping. A little bit of scalp discomfort or scalp sensitivity at that site. Maybe a bit of headache. The 23% reported in broad studies for headache is probably about what we've seen at Skyland Trail. I'd say between 15 and 25% overall. Very, very low discontinuation rates based on side effects. We have not had a single patient need to stop treatment because of discomfort. Overall, if you look at the studies again in the real world sense, about 1 to 2% of patients will say that this is not a tolerable treatment. That is obviously significantly lower than most other treatments like medications or ECT. The one scary thing that's honestly, again, more of a theoretical risk at this point, it seems, is that about 1 in 1,000 patients in the initial studies had a seizure as a result of treatment. So, again, this is a direct stimulation of the brain's cortex. That is something that, when we use it therapeutically, like in electroconvulsive therapy, we know can occur. We are not using anywhere near the power typically required to generate a seizure, nor are we doing it in a spot that is particularly conducive to generating a seizure. And it's something we still want to make patients aware of. All those contraindications like drug or alcohol use, head injuries, history of meningitis, those issues are all related to seizure risk. So if we have someone who's more prone to seizures because they've either had them in the past or because their family has a history or because they've had 6 or 7 concussions, playing college football, I think those are all really important things to think about and often don't change the risk stratification very much towards moving away from TMS. Rarely patients will pass out. That's that kind of vasovagal reaction that some people have when blood's drawn and things like that. We keep a very close eye when we're starting treatment to make sure that everyone's healthy and kind of off to a good start, and they're not experiencing any dizziness or feeling woozy. In the old protocol, where we only did left-sided treatment, again, anxiety would be reported as increased in the first few sessions for some patients. This has been largely mitigated by adding in the right-sided treatment. So with our new protocol, left and right side, we at Skyland Trail have not seen an increase in anxiety, and the case reports and kind of smaller studies that have concluded at this point, it also doesn't seem to increase anxiety when you add in that right side. And then again, no cognitive issues, no amnesia, none of those issues that you might have to deal with electroconvulsive therapy. Effectiveness, I mean, this is really what it comes down to, right? Is this a more effective treatment? Because that's what we need. There's at least 30 sham-controlled, so high quality trials with over 2,000 patients at this point, and these are just only the trials that are deemed high quality, that demonstrate both efficacy and safety. So what you'll commonly hear if you're asking about what the effectiveness rates are is about half of patients will respond and about a third of patients will reach remission. Again, response, as I kind of mentioned earlier, is defined as a 50% reduction in their symptom severity. So we take a depression scale, we ask them questions, and we rate their scores on a number of different categories at the beginning of treatment. A response would be a 50% reduction in that same scale when they conclude. Remission means that they're basically at the point where the symptoms of depression are not clinically significant, not impacting them significantly on a day-to-day basis. So this is kind of the end zone, so to speak, for this treatment. This is what everyone's looking to achieve in depression and mental health treatment as a whole. These are defined numbers. It's an 8 on the Montgomery-Åsberg depression scale. So basically anything below that is remission. These are sort of cut points in the scale itself. Now, those 1/2 and 1/3 numbers are based on essentially the entirety of TMS literature. Here's what we're actually achieving. And this is, I will say, to preface this statistic, slightly better than the community, but this is where it's all heading. We are now seeing patients achieve about 80% response rate and a 52% remission rate at Skyland Trail. Now, the beautiful thing about Skyland Trail is that we have the benefit of excellent psychotherapy and evidence-based decisions around pharmacology to support the TMS. So this is not in a vacuum, clearly. I'm the first one to tell all the patients it's not just TMS. It's certainly not just me. This is the junction of all the work they've done to kind of get themselves better on a variety of different fronts. And I always tell people at the end of TMS, if they don't keep doing what they were doing in terms of psychotherapy and medications, it's not clear whether or not they'll continue to have the results they've had. But we have had excellent results. I mean, these are for patients who have been largely treatment resistant, even to a degree that's outside of what you would see in normal treatment resistant depression clinics. By the time you're reaching a residential level of care or intensive services level of care, things are going in a way that's fairly treatment resistant. We've dropped people's score on average on the depression scale from 30.2 to 9.3. So again, severe down to mild on the edge of remission for the average patient. And then from an anxiety standpoint, again, this is actually even more clinically significant. A high, moderate to low severe average start point for the Hamilton Anxiety Scale down to a 6.81, which is in the mild range. So again, we were thrilled to see that people were responding as well with their anxiety based on TMS experience as they were with depression. That was not totally expected and has really helped a number of patients, because we've been very few patients who have come into us and said, depression's the only problem I have. I'm not anxious at all. These things often run together. So we've been able to help with both. And again, let's just compare that to STAR-D, that stepwise depression trial. By the time you're reaching step 4, indicating 3 or 4 medication trials and some psychotherapy, which is basically where patients come into TMS, you're looking at only 7 to 10% remission rate if they were to try their next medication. So substantial improvement from where we were with our standard psychotherapy and meds. Durability, also obviously an important part of this. Systematic analyses, and we've given almost 20 years worth of data at this point, 19 bigger studies and more reliable studies. It looks like at least a half of people will sustain their response at a full year. So again, huge increase in the durability from something like an electroconvulsive therapy where you need to do maintenance. It's also obviously significantly better than the rates we saw earlier with STAR-D and depression with just meds and therapy. We don't yet have a great way of defining how to maintain the treatment, meaning after you finish your initial 36 sessions, kind of what do you do from there? Do you do boosters? Do you do maintenance sessions? There's 3 main ways of going about it. One of which is to do an extended taper where they, rather than just tapering over the last 3 weeks, we add in sessions and then taper out so that they're maybe finishing out with 1 session every couple weeks, moving to 1 session a month, moving to 1 session every few months. Some people just do planned boosters. I have a few patients doing this right now. So every month they will come in for 2 to 3 sessions to try and, again, lengthen the amount of time that their treatment will take effect or will have effect. And then the most common way of actually going about this is just watchful waiting. So you have a patient finish, they get a good response. You instruct them that as soon as they feel like they're starting to slide back towards depression, they give you a call, they talk to their psychiatrist, and you coordinate to get them back into treatment for some maintenance treatments. So that's an overview of what we're doing. I think if you look at Skyland Trail's protocol, that is fairly widespread in terms of how that's utilized at most of the major academic centers and other higher quality TMS centers in the country. The really fun thing about TMS is that, we often have patients come in who have really struggled. They've tried incredibly hard at, their psychotherapy, and they've started to see a little bit of benefit, but it's never quite taken hold. The medications just haven't quite lived up to their billing in terms of keeping things at bay. And they come into TMS and, without having to add more medications to the list or, dramatically change their life other than when they come in for sessions, they get a great response. And the other really exciting thing about TMS is that we are only starting to understand the potential applications of this treatment. And at this point, every month, it seems, again, that like there's new indications coming out, there's new protocols for driving this treatment. And I'd like to share with you a little bit of, what's on the frontier for TMS moving forward. Because I think, honestly, this is a way that we can expand the benefit of TMS to patients beyond just depression, and as we'll see, OCD now, which is also covered. This is a picture that gained some notoriety a few years ago. A researcher, a psychiatrist by the name of Michael Fox, not the Michael Fox, obviously, a gentleman who has gained a lot of notoriety in TMS and in neuroscience research, really expounded on a concept called the connectome. And his thought was basically that rather than treating the brain like a bag of neurochemicals, which was kind of the original way we treated it way back in the early parts of psychiatry, and even more than treating it as specific locations like the dorsolateral prefrontal cortex or the amygdala or the nucleus accumbens, what actually matters more is how those different areas communicate with each other. And when you stimulate one area or when one area becomes active, what other areas light up in response? What is the functional connection between different spots in the brain? So to give you an example, if we activate the hippocampus in someone, right? So a memory and kind of emotional salience center, and we bring in the amygdala, which processes fear. If that hippocampus and amygdala are tightly wired, and especially if they're tightly wired to the frontal cortex in a way that sort of decision-making, active thought processes, executive functioning, and kind of task completion are all intimately connected to fear and memory, what we start to see is a very anxious approach to decision-making and difficulty functioning in social situations. I'm being a little bit broad with this right now, but I think, for the purpose of demonstrating, if you've got your frontal cortex and all your decision-making centers too tightly wired to your fear centers, that's probably more important than, again, knowing how big someone's amygdala is as a whole. And what we know too, and again, this is actually a neuroimaging kind of illustration of different connections within one patient's brain. What we know is that with TMS, with psychotherapy, with medications, when they are working well and when they're doing what they're supposed to do, people's brains actually start to rewire, for lack of a better term, and the connections change. So you get more of the areas that are, involved in healthy decision-making and more rational decision-making at the core when you start to bring in problem-solving tests and things like that. So, again, that's just one direction we're heading here, and that's just a beautiful illustration of what the connectome looks like. It's really driving how we're looking at psychiatric treatment as a whole moving forward. Really moving forward, we do have, not just new protocols and new target site optimization, where we're actually targeting the treatment. We're going to be able to use this for a number of different diseases as well. One thing that many people who are familiar with TMS have probably heard about, it's starting to gain some more broad coverage. I saw it in I believe it was New York Times a month or two ago. They had a quick article about the 3-minute cure for depression. Intermittent theta burst stimulation. So theta burst is essentially a way of doing TMS that rather than taking 15, 20, 30 minutes to do high or low frequency treatment, it actually takes advantage of our knowledge of the way that brain rhythms and neuronal firing within the brain happen in a healthy brain. And it mimics those and sort of retimes the brain, so to speak, in terms of neuronal firing in a way that, again, brings people back towards health. It's basically bursts of bursts. And the punchline is that you can deliver the 600 pulse protocol in just 3 minutes and change. So that allows a lot of flexibility. Number one, it's more tolerable. So patients who don't want to sit there for 40 minutes either because they have trouble sitting still, I'm thinking of younger patients in particular for that reason, kids and adolescents, but also folks who find it painful, and people who don't have 4 to 6 weeks to wait. In this case, with a 3-minute session, what we're looking at is the ability to do potentially 3, 4, 5, and as you'll see in one of the upcoming slides, up to 10 sessions in a day in a way that really just cuts down the amount of time it takes to get somebody to remission. We also think that this endogenously based theta rhythm and the induction of that rhythm is more conducive towards long-term synaptic potentiation. So long-term changes, developing those connections in a way that's more robust and longer lasting. And obviously, again, the efficiency and tolerability are a great side effect. Lancet came out last year. It's a very highly regarded British journal. They had a study last year that was, or I guess now 2 years ago, that was definitive in the acceptance of theta burst stimulation as an FDA-approved treatment, which it now is, non-inferior to regular TMS treatment. So basically, you're getting the same results, at least, with theta burst as you are with regular TMS. And now, I will say, and to give a nod to one of our colleagues, the SAINT trial, published in the AJP in 2019, this is Dr. Schatzberg and his colleagues at Stanford. He's one of our professional advisory board, national advisory board members, and has really been critical in developing this program. They did a really groundbreaking study last year where using functional MRI guidance to actually place the magnet, they were able to take 21 patients, essentially do the intermittent theta burst stimulation protocol, slightly more pulses per session, but they did 10 sessions a day for 5 days with this MRI guidance, and they achieved 91% remission with significant results at 3 days. And now, if you're thinking about, a loved one with depression and the difference between, 6 weeks to recovery or 4 weeks to recovery and 3 days, you're talking about a totally different subset of patients who you can impact positively with this treatment. So that was a very exciting paper to come out. They are doing the follow-up studies to that right now, to sort of blinding patients so that it's not obvious to them that they're getting the treatment. That helps ensure quality and replicability in the real world. And here's Mike Fox and his connectome idea. We do know that symptoms correspond more closely to networks of connected regions than the regions themselves and just specific spots. So thinking about how the brain connects inside of itself is probably the most critical thing we'll look at moving forward. That's a big paradigm shift for us in the field in the last 10 years or so. And then, for depression, again, we know that that limbic system impacts a lot of other different sites within the brain. And, right now we know the prefrontal cortex is a good access point. We don't know if it's the best access point. We're just doing a lot of research to try and figure that out. As Dr. Schatzberg and his team have shown in that SAINT trial, literally, the way you go about placing the magnet and targeting the treatment should be individually specific as far as we can sort of guess at this point. That seems to be the case. We are hitting most people very effectively given our current protocol, and we can do significantly better, we think, if we know certain aspects of the way their brain connects using things like functional MRI. The reason that trial has not taken wide effect, and why we're not all doing the SAINT protocol, by the way, for our patients at this point, is because it's extremely expensive. I mean, it's cost prohibitive. This is something that could only happen in an academic center at this point. But we are looking towards ways to make that more affordable and more widespread. And then really interestingly, Harvard group, and Shan Siddiqui's the lead researcher on this, is essentially looking at not just depression, which is an incredibly heterogeneous disease with many different manifestations, and not just trying to treat depression with TMS, but trying to treat specific symptom clusters. And his landmark paper basically showed that if you have a patient who is anxiosomatic primarily, so lots of physical symptoms of depression and anxiety, insomnia, again, that type of anxious, agitated depression, doing a treatment that's slightly more posterior in terms of that location on the brain is actually probably a more effective place versus patients who are more melancholically, classically depressed, can't get out of bed, low energy, low motivation. Those people seem to do better with more anterior placed magnet. So again, we're not just thinking about depression as this incredibly broad category and we treat everyone the same. We're starting to break it down in terms of their specific symptom cluster and presentation and locating the coil specific to that. And just to finish up, so we have a little bit of time for questions too. Some people who have heard about TMS have heard about this, quantitative EEG or QEEG or EEG guidance or neuronavigation. These are all kind of stock lines that the manufacturers are using to describe ways of mapping the brain and or locating the magnet more specifically and ensuring that the magnet ends up in the same place every single session, which is a bit of a challenge in and of itself. And the new systems, including the ones that we're trialing for Skyland Trail in the upcoming year, mostly have 3D guidance systems that ensure that you're in the same place every single time. Another interesting concept, it seems like, again, towards the bottom of the screen here, you can see this little cutout from the headline of an article in Brain Stimulation, which is kind of the leading TMS journal. It seems like the placement of these magnetic pulses and where they fall in the cardiac cycle, so meaning, essentially the way your heart's beating, the way that the nervous system and the cardiovascular system is relaxing and tightening and responding to neurologic stimulation actually matters in terms of how the result of the TMS comes through. So in other words, if we can sort of time it correctly, not between heartbeats, but in correlation to the heartbeat and the heart rate and heart rate variability, it seems like we can actually get a better effect that way too. That is, as you can imagine, a pretty high level thing to research and study. It's hard to deliver, but I mean, that's the level that we're getting specific about how to deliver TMS. And it does seem like this is the way things are headed. Exciting development in late 2018. We had BrainSway as a manufacturer, and their H-coil was approved to treat OCD. So you saw almost a 40% improvement in OCD patients who were a part of that trial. Significant difference from the sham device that they'd used. And, again, for a very hard to treat disease like obsessive compulsive disorder, a real breakthrough in treatment. That is currently still only approved to be treated with the H-coil that only BrainSway makes. So they're sort of becoming a more widespread treatment, but not quite as widespread as typical TMS. And, really here's a picture before we move on. Kind of a comical looking device at some level, but you can see it actually covers quite a bit of the brain and delivers a pulse, broadly through the front part of the brain and that anterior cortex. And And that's sort of how we treat OCD at this point using TMS. That is the one machine FDA approved at this point. We think that this might actually provide a treatment for schizophrenia as well. So anyone, again, who's worked with or knows people who have suffered from schizophrenia, we are not terribly bad at controlling the positive symptoms, the delusions and hallucinations. We can do okay with that. We are not as nearly as capable of treating the negative symptoms, right? The social withdrawal, the emotional blunting, the sort of loss of function that people experience as a result of schizophrenia and the treatments of schizophrenia. This seems to be one potential option for treating that shows a level of efficacy that might actually be workable moving forward, which again is really, really exciting for the field. This has been sort of a bugaboo for the field for years, that we can't treat negative symptoms of schizophrenia. So this would be a huge leap forward. We're looking at it in conjunction with clozapine therapy and a number of other therapies. And then kids and adolescents, right? This is kind of the last thing that we need to achieve FDA approval for. Currently, it's 18 and up for depression with regular repetitive TMS. Studies seem to show that it's just as effective and probably as safe as doing TMS in adults. The only thing we're not 100% sure of is exactly how transcranial magnetic stimulation affects a developing neurocortex. And the studies are sort of happening right now, as you see at the bottom there. Neurostar, who's the manufacturer, is conducting a huge, well-blinded study related to use in children and adolescents, and it seems like those are positive results so far. So hopefully not too long before the FDA clears it. I will say that many places are already doing TMS for kids. It's just not approved by the FDA and therefore not covered by insurance. We're going to be able to treat, it seems like, insomnia relatively soon, bipolar disorder and bipolar depression in particular. We already see great results with GAD and panic, using our traditional protocols, and we can probably do even better if we can target it more effectively. PTSD's got a lot of the research right now for TMS, lots of studies coming out on a regular basis related to PTSD, so we're close there. And then ADHD and executive dysfunction, as well as substance use disorders and addictions, Parkinson's, other dementias. I mean, there's just a number of things we can treat besides the current indications. So again, just take-home points. This is a safe, well-tolerated, highly effective treatment. For patients who have otherwise not responded to other treatments in particular, this is an incredibly robust option. Low rates of relapse. And we're only getting better by the day as we learn new protocols and we learn more about how the brain's actually responding and functioning within a TMS treatment. As we improve targeting and get more options for targeting, we're only going to get better again. And I think what I'm going to see in the next few years as a TMS provider is more and more patients being eligible for this. And so I'd encourage you to continue keeping your eye on the TMS research to see when patients who are suffering from things other than just major depression might be able to receive treatment as well. Okay. Well, thanks everyone for letting me kind of mow through all those slides and get through all the content. I think we've got a little bit of time left for questions, and I'd love to hear kind of Dawn what you've seen as some of the bigger themes, or if you want to throw me a few of those questions, I'm happy to answer them.
Sure, I'm glad. Great job. You answered a lot of them as you went along. One thing I would like to just tell everybody before I get to the questions specifically is that we have recorded this. And if our technology went the way we hope it did, then we will have that recording available, because there was a lot of information in there. And some of us might want to hear it again to make sure we've gotten everything. A couple of things to risk factors, Dr. Hunter. One is, would a arrhythmia rule out a person as a candidate for TMS?
Yeah, good question. An arrhythmia in and of itself is not a contraindication. A pacemaker would be a challenge. The electrical introduction of that magnetic field would interrupt a pacemaker. The electric field in and of itself is conducted locally in the brain, so that would not affect the cardiac rhythm.
Great. Another person said, and you addressed this briefly, but have you known of anyone having memory problems from TMS?
I have not. I've actually seen a number of patients, and actually one of the more commonly reported initial sort of recovery points for people going through TMS is that they start to feel more clear cognitively. What I do hear people say sometimes is that in the hour or so following the session, they kind of feel a little like just off, not slow, not having memory issues, frankly, but just kind of, I think it's more a result of having their head tapped on for half an hour that sort of makes them feel a little bit less than, exactly like they were before the session. But it's not unsafe to drive. It's not unsafe to return right to normal activity afterwards. We do not know of in any of the studies. There have been a lot of studies at this point long term. We do not know of any of the memory issues that are sort of very common actually in ECT occurring with TMS. It seems to actually probably promote memory a little bit.
Great. And then Mary Louise asked if you can comment just a bit on TMS treatment of anxiety/depression related to a young adult woman with high functioning autism.
Yes, and it's funny. There's actually a really important study being done right now for major depression or depression symptoms in patients with autism spectrum disorder. So we'll have a more definitive answer to that, I think, soon. But the answer is right now, we have treated patients who have autism spectrum disorder who have similar symptoms of depression with the same protocol, and we've had good results so far. That seems to be the case. There's mainly case studies and small reports in the literature at this point with autism spectrum disorder. But if you're talking about the depression symptoms, they are in some ways neurobiologically similar, it seems. And I think when it comes to treating other symptoms of autism, you might be looking at a totally different approach, and I can't speak as well to that. But from a depression standpoint, it seems like we do fairly well.
Great. And Cindy Ferguson asked, hey Cindy, if a patient begins to feel depressive symptoms a year out after TMS and they receive booster type treatment, do they return to the same level of benefits that resulted after the initial 36 treatments?
That's a great question. And the answer is yes. And that is a really encouraging statistic that we've found through all of our studies on durability. As many of you know, one of the issues with medications is if you stop a medication that has been effective, so let's say someone's in remission on Zoloft for a couple of years, and they decrease that dose until it's low enough that they're comfortable, and unfortunately the symptoms come back, Zoloft is not necessarily as likely to be effective as it was the first time around. That's a phenomenon called tachyphylaxis, which is widely acknowledged in psychiatric pharmacology. That is not the case with TMS. It seems like patients who have responded once actually tend to respond again. We've had, I want to say 3 patients come back now for boosters, and all 3, and one person has come back twice, excellent, actually better than the first time around in terms of their response on the second and third go round.
Great. We have a lot of other questions, but we're just about out of time. So I think I'm going to stop with one more. And that is, at what point do you stop TMS if the person is not responding?
That's a good question. Given that the harm profile with TMS seems to be very low, we're mostly just limited by the side effects of the session and the cost in some cases. And adding in one more point of data, which is that I have seen a number of patients, and if you look at the studies, a number of patients respond right at the end of treatment. It's hard to want to quit on this early. If a patient's having a really difficult time tolerating it, and I think that's the reason why they're not doing well, in some cases, we try to back the power off and otherwise might cut it short. That just hasn't been the case for us so far. Excuse me. We've been able to continue through, and at this point, I think for most people, I always give them the choice and say, listen, this is an hour of your day. There's some financial involvement, and there's a little bit of discomfort, and we haven't seen anything yet. I have reason to believe you may still respond. I mean, probably a little bit less likelihood than when we first started, but there's still a decent chance you could respond. It's hard to quantify. Do you want to keep doing it? And without fail to date, people have said, yeah, I've started this and I kind of want to finish it. I haven't yet run into the situation where someone is giving up a major part of their life to come back to treatment every day. Meaning we've been able to schedule it in a way that most people, it's sort of an add-on to their day and hasn't prevented them from going back to work or anything like that. But, I think as competing interests become a question, that might be something to consider. But yeah, we've had everyone essentially, even when they've been struggling, middle to the end of treatment, want to continue. And, one of the treatment outcomes is certainly that some people just don't seem to be quite as robust a responder to TMS. There's a certain group for whom TMS will not be incredibly effective. And we've had a few of those, certainly. And in that case, I think it's realistic about, a discussion with the patient about, what their odds are if they're at session 32 and they've not seen any improvement. And, you know, it's a talk about what the next steps are and encouraging them to continue with the next steps in the treatment, because what we know is that, you know, lack of response to TMS does not change someone's response rate to ECT, and vice versa. So we've had patients who have failed ECT and successfully been treated with TMS. But what I basically do is try to encourage somebody, number one, to finish the course, especially if we're seeing any improvement at all. But secondly, to continue on and not kind of give up. I mean, TMS is never the end of the line in terms of treatment.
Thank you, Dr. Hunter. I'm going to throw it to Julie right now to sort of finish things up, but there is one person in particular who would love it if you could stay for a couple of minutes after and answer some questions, particularly about treatment of bipolar disorder.
Sure.
I don't know if you've got time or not. So
I do.
Okay, Julie, you want to just do the wrap up, and then we'll, anybody who would like to stay on for a couple of more minutes with Dr. Hunter, I think he can give us a few more minutes.
Hey everybody, I'm Julie Didkowski. I'm one of the 5 National Referral Relations representatives here at Skyland Trail, and I'm actually based in Atlanta. Just wanted to take a minute to thank everybody for joining us today. We're so happy that you're able to take some time out of your day. And we're especially happy that we were able to reach people not just here in the local Atlanta community, but had some folks who've joined us from states across the nation. So we're really excited to reach all of you. Just to reiterate what Beth said, we really look forward to working with our partners in the field and our friends in the community to assist those families and clients who are really struggling during this very difficult time. I hope you'll be able to join us at some of our future virtual events, which are on that slide. And hopefully in the not too distant future, maybe you can come and join us on campus for some events too. Hopefully in the fall, we can host Arts in the Gardens, which would have been today. So I hope you can join us for our annual birthday celebration, 31 years old this year. And please feel free to reach out to me or anybody at Skyland Trail if we can help in any way. And thank you for all that you do, and please stay safe, and we hope to see you again soon. Thanks so much.
Thank you, Julie. Thank you, everyone. You know, Dr. Hunter, I think if you unshare now, yeah. Then maybe what can happen is, Amy, you could just go ahead. Some of the questions I think you've asked, he's answered, so maybe you want to just go ahead and ask him more specifically. Amy, are you there?
Yes, I am.
Great.
Okay, Dr. Hunter, I was wondering if these same, if everything that you have said about the use of this for depression is true for OCD. From both how you do it and the medical insurance coverage and the effectiveness.
Yeah, so different protocol with that H coil that BrainSway makes for OCD. It's a shorter treatment actually. Each session, as you might have noticed on that slide that had the actual picture of the coil on there. It's sort of like a bucket shaped coil, so there's no sort of sidedness to it. It's just one treatment, 600 pulses. It is covered by insurance fairly well at this point, it seems. Maybe not quite as well and as widely as depression, but certainly has been an option for patients. I think the limiting factor actually at this point is probably the number of psychiatrists who have access to an H-coil. It's sort of a totally different machine than the normal TMS machine, so it's a pretty big financial investment to pick one of those up to treat OCD. I think it's mostly at specialty centers and academic centers. But yeah, I mean, the effectiveness rates, again, you're talking upwards of 40% of people responding in a very resistant, classically resistant disease. Again, I think to the benefit of many of the therapists in the audience, exposure therapy is still the gold standard there. But I mean, when you can add in a little bit of biological relief from the deep TMS to do your exposure therapy, I mean, that's an incredible combination.
Okay, thank you so much.
Just real quickly too, Dr. Hunter, there was two questions kind of related, I think. Do you recommend either active stim or Fisher-Wallace stimulators for home use? And if so, which do you prefer?
That's a good question. I I think I spent more time trying to figure out how to answer that question in the last month than just about anything else, especially with coronavirus, right? I was actually just reading an article in Brain Stimulation the other day that was oriented towards, you know, the way we need to think about neurostimulation in a world where people can't get outside the home, right? And that's really what we're facing right now. And there's a few different avenues that people are going about this. There's actually at-home TMS devices being developed. So it's basically like a helmet that sort of obviously self-orients and is programmed by a psychiatrist, but is able to be used at home without actually having to come in. That's sort of in the early development. There are vagal nerve stimulators that actually are preauricular, so they will stimulate the vagal nerve via a sort of like an ear clip type device, as opposed to an actual stimulator that's surgically implanted. Those are nice because they can be used at home. And then there's direct current stimulation. So these direct stimulation, they are electrically based, and you're sort of getting the same technology with those two devices, Fisher-Wallace and AlphaStim. You've got essentially an electrical current that is passed through the head in a way that's also meant to target that same limbic system area. And it's not, here's what I won't say. I will not say that it looks totally unfeasible at this point. I have said that about a number of things over the years. There's a number of things that are unfortunately pitched to help treat people with resistant depression and other illnesses who are in such a state of desperation, anything to work, and they're sort of taking advantage. I do not think this is like that. There is good research being done about these devices. I'm just not quite at the point where I could recommend it. But I will say this, it seems like the safety profiles are very good on these. I have not seen a lot of issues with them in terms of safety. So coming short of making any kind of clinical recommendation, wouldn't be able to say one over the other, but the technology itself seems to be a direction that we're heading that seems fairly positive. So I want to come just short of saying it can't hurt. I wouldn't want it to stop anyone from getting TMS or otherwise pursuing other treatments that we have a little more evidence about, though.
Okay, I think we've taken 10 extra minutes of your time. So let me see, there's 2 quick messages I'll look at. Bonus question. No, I think we've got it. So thank you, Dr. Hunter, for the extra time, and thank you for everybody for attending today. And that will conclude this session.
Thank you, Dr. Hunter, and thanks all.
Thanks everyone for coming. I really appreciate you being here.
Thank you.
Stay safe.
Bye. Thank you.
Bye.
Bye.
Have a great weekend.
Y'all too.
You Atlantans enjoy the beautiful weather here.
We will. Bye, Julie. Bye, Dawn.
Bye, Sylvia. See you next time.
Okay.
Bye, Sylvia.